I would like to hand over to Märta Segerdahl, who is a medical doctor, PhD, and an associate professor, and who is also our chief medical officer. Please, Märta.
Thank you, Martin. So being the chief medical officer of AlzeCure Pharma is super interesting for somebody like me, who is a specialist in pain management and also have been doing clinical research and having seen clinical patients for many, many years, and then joined industry several years ago, working both actually within pain, but also within neurodegeneration. So pain has always been known to humans. We've had pain, tried to cure pain for thousands of years. Even the Iceman, Östio, was found in South Tyrolia, had acupuncture marks on his back. And there have been findings of marijuana in Stonehenge. So this is something that actually followed us for thousands of years and probably before that. But it hasn't really solved the problem. We need something new that is more efficacious. And since we still have pain as a huge problem, we need to understand what is it. So it's an unpleasant sensory and emotional experience that is caused by an injury or trauma, or reminds of such an experience. So actually 1 out of 5 individuals suffer from chronic pain, and that's a significant amount. And a large proportion of them actually have neuropathic pain, which I will tell you a little bit more about. This, of course, has huge implications for GNP, so for huge direct costs, but also it's the common reason for work disability that is the most common in Europe. It's as large as all of the psychiatry together. And that is something that people aren't normally aware of. So it's time to bring that up to a more common knowledge. And of course, it also affects the individual with large indirect costs, with economic burden, poor quality of life, and for poor physical function, and this leading to very poor mental well-being. And the chronic pain population is particularly vulnerable when it comes to suicide risk. It's as common in chronic pain patients as it is in depression. And it's linked directly to the intensity of pain. So if we can do anything to reduce the intensity of pain in patients, even if we don't take it away, that's going to not solve the problem, but it's going to make it much easier to cope in life. So every one of us has actually experienced pain. Toothache, or you sprained your ankle doing sports or something of the kind. And then it heals and pain goes away. But for some individuals, this pain persists long after the injury has healed. And then we call it chronic. And at that point, there is this reorganization in the nervous system, both in the peripheral nervous system and in the brain and in the spinal cord. And at that point, pain has become a disease of its own called chronic pain. So in the acute sense, it's a warning signal that we should take account of and act by. But in the chronic sense, in the long term, it's actually something that is unnecessary and does not help us. So there's different types of pain. So in 3 major types, there's a whole bundle of different sub-indications, but 3 large portions, which one is the nociceptive pain, which most people know about, is pain in osteoarthritis, in gout, after trauma, from cancer tumors, and other things. Neuropathic pain is often less well known. It's pain due to either a disease, a progressive disease, or as of the nervous system, but it could also be a long-lasting pain after an injury to a nerve, for instance, after surgery or trauma. And at the bottom, you see something called primary pain, nociceptive pain. That's something that we will not talk about today at all. It's indications like fibromyalgia, which most people have heard of, and we don't really know what causes them. Now, for nociceptive pain, we have a number of typical conditions. So for instance, osteoarthritis pain or chronic low back pain, which is normally at least partly a part of osteoarthritis pain. But it also includes pain not only for joints, but also from adjacent tissues like tendons and muscles. Very many people in the world actually suffer from OA pain, either in the West world because we don't move around enough, we sit too much, or in poorer areas of the world where people are overstrained. Very many people have chronic low back pain, probably some of you, I would guess. Our standard of care, which is non-steroidals like diclofenac or ibuprofen or naproxen, they actually have poor efficacy in these chronic conditions, as do the second line analgesics, for instance, like opioids, which we know also are prone for tolerance development, and they have an abuse potential. Sometimes we inject steroids in the joints. That's also quite invasive. So we need something that's actually better than that. So for treatment gaps, then, if 5 out of 6 don't get sufficient pain relief with existing therapies, that is something we need to address. But that could be either due to that they don't respond, or that they have so much problems with their side effects that they actually cannot continue taking them. And a lot of people actually should not take them because they have heart disease, or they have asthma, or other conditions where it's not compatible with their disease mechanisms or their drugs for that matter. We had great hopes to the anti-NGF antibodies that were under development for many years. They were not approved as late as this year because of the increased risk for side effects compared to the potential benefit. So that's another sort of hope that went down. So currently, there's a number of different research projects looking at understanding disease mechanism, and then also to develop new disease modifiers. But we don't have anything yet. So we really need to have something that can help attenuating these symptoms of long-standing nociceptive pain. When it comes to peripheral neuropathic pain, a large number of these patients suffer this as a lifelong condition, even progressing over years. Now, there's a number of different groups of patients, and I would like to start with this one, which is the largest group, which is painful diabetic polyneuropathy, or other types of painful neuropathies, where they describe their symptoms as pins and needles, constant pins and needles in your feet, for instance, or even your hands. Or they can describe it as they're walking on coals on fire. Not very, it's very descriptive, but it's not something they would like to experience ourselves. There's also patients who have problems after nerve injury, for instance, after surgery or other types of trauma. And they have to be really careful when it comes to different stimuli. So it sounds like stimuli is something not very problematic, but it actually is that perhaps they cannot wear their bed sheets because it hurts so much when they have them to the skin, or they are afraid of going on public transportation because they can bump into people, and that causes them an increase in the pain that will last for many hours. Another group is actually patients with post-herpetic neuralgia, which in Norwegian and Danish is actually called hellfire. And they are very sensitive to touch, and this is actually quite common in elderly people who have had shingles. So they're extremely underserved because there's nothing really that helps them. So neuropathic pain is common, but it's invisible. One thing is because you can't see that there's an injury, but the other thing is that these patients don't necessarily go out and mingle and talk about the neuropathic pain. About 10% of patients suffer after surgery. And there's a number of different, this is just a listing of different indications or different states and diseases that can actually also have pain as a part of the symptomatology. But looking at the numbers, if you look at painful diabetic neuropathy, for instance, as many people suffer from that as patients suffering from Alzheimer's disease. So what is the impact for the individual and for society of chronic pain? Well, of course, the health-related quality of life is rather poor. Is rated as poor as for patients with severe heart disease or depression, or poorly controlled diabetes. It's also a disease of the family and friends because you have a limited social life and your family actually needs to cover up for whatever abilities you don't have. So quality of life is more dependent also on the severity of pain than on its underlying cause. Normally, we say that neuropathic pain is more severe, and that's not because it's neuropathic, but it's because it's persistent. So usually patients stay up at night, they can't sleep because the pain is often worse at night when you're supposed to sleep. So therefore, it's associated with worse health and also increased suicidality. In a survey that they had in the UK a number of years ago, 17% of those who had neuropathic pain, they actually scored quality of life as equivalent to worse than death. This sounds very terrible. And you say, well, don't we have therapies? Well, we don't have very many therapies. The two tools that we have, they don't fit all. And instead, we need to have a better understanding so that we can develop a toolkit that will enable us to drive development to give us the right treatment to the right patient. We're not there yet, but we can see that it's coming in the future. When it comes to neuropathic pain, there is a really high unmet need for new treatments. As you can see, these charts here, the blue sections are actually the number of patients who, if you look at it in the long term, are actually helped by these therapies. So it's not necessarily so that you add up the different sections and you have half the cake, but they actually sum up to about 1/3 of the cake. So 2/3 of patients are not well treated at all. There's also it doesn't say that, or it doesn't mean that these patients nobody has any help, because they happen to help a subset of patients, but we can't tell at this point in time who will be helped from what. There's also a number of other treatments that are less well used or that help an even smaller subset of patients. And we don't necessarily want to use opioids because they don't help. They're not efficacious, and they also have a lot of side effects, as we've become increasingly aware of these last 20 years or so. The situation is not much better in chronic neurosusceptive pain like OA pain and low back pain. So in the acute state, you can have some help from nonsteroidals, but they still don't help everyone, and certainly not in chronic low back pain. And also, nociceptive pain increases with age. So more and more people, the older you are, the higher the risk that you actually have or develop chronic nociceptive pain. But that also increases the risk or the probability of you having cardiovascular disease, asthma, gastritis, and a number of other problems, like renal failure, which mean that you cannot or should not take these medications. So the topicals are good for sprains and strains, but they don't have very good efficacy over time. And opioids that people say, well, you can always take an opioid. They're nice and strong. Yeah, they're strong and they're very good in acute pain, but in chronic pain, they don't have a place in the treatment palette. So in summary, still 1 out of 6 to 7 patients actually have good efficacy of the treatments we have. And as you can see from the total numbers, that means that there's a lot of patients who actually need new treatment options. As we become more and more aware, this opioid epidemic in the US has put focus on opioids as abuse deterrent or abuse liable. And there is a huge drive and need for development of drugs that are non-opioids. And actually in the US, the FDA and the NIH and other agencies, they actually promote the development of non-opioid painkillers. So in summary, chronic pain is disabling, and it affects about 1 in 5 people worldwide. These patients have a very low quality of life. This chronic pain and so low quality of life also has a huge impact on employment because they can't stay at work because it's painful and they get fired. Family economy is, of course, suffering physical function and thereby also mental health. So those are the indirect costs, but also direct societal costs are very high. So there is really a high unmet need for better and more specific and safer treatments. And that's why I think it's so fascinating to work at AlzeCure, where we actually have two options of developing something that is new and hopefully will improve the situation for all of these patients. Thank you.